Good morning. Thank you very much for inviting a pathologist to join this prestigious ENT conference. So it's a great pleasure to talk about, and also challenging to talk about head and neck soft tissue and bone tumor. So, well, how challenging it is. So this is the outline. So I'm going to talk about, of course, the challenges and also the WHO classification, the background concept, and also some standing issues about this classification and diagnosis, were supplemented with an example of a challenging case. And of course, it would be a shame to not talk about some selected soft tissue and bone tumor specific to the region. But back to the question, how challenging it is. So this is the latest head and neck pathology journal. So you can see that it's a special issues on soft tissue and bone tumor. And this is all the special issue topics. So with different areas like adipose tissue, muscle, perivascular, etc., etc. So it would be difficult to cover all this topic in just 15 minutes. So therefore, instead, I'm going to talk about the general concepts and idea about this classification and also diagnosis. Well, of course, we now talk about the head and neck tumor, but at the same time, we also talk about the soft tissue and bone tumor, in which there's a specific and separated classification system dedicated to soft tissue and bone tumor. So I will start with this general perspective about the soft tissue and bone tumor, so to understand better about the challenges in the, related to the head and neck region. So what is so challenging? What I always talk about is a challenging area. So how challenging it is? So, well, first of all, it's rare. So sarcoma is rare and is further subclassified into 70 subtypes. And not to mention that if in head and neck region is even rare, as a rare to have a primary soft tissue and bone tumor. So that's cause the challenges. And of course, the intrinsic complexity in the pathological diagnosis. Because, a lot of time for this soft tissue and bone tumor is actually violate the general understanding we are so familiar with in the diagnosis of, say, the squamous cell carcinoma or nasopharyngeal carcinoma. Those diagnostic criteria, say cellularity, mitosis, may not be applied to for the diagnosis in a lot of times in the soft tissue and bone tumor. So I will supplement with an example later on. And of course, nowadays, the technological complexity, because as more and more of these molecular diagnoses are now emerging, so we now rely more on these molecular diagnostic tools, say FISH or PCR or even next generation sequencing. So it adds to a more complexity to the diagnosis. And of course, still clinical correlation and also morphological features are still variant. So that it all adds to a very complex picture about the diagnosis and also the classification of these soft tissue and bone tumor. So what's this classification? Well, of course, we know very much well about the WHO classification. We have a special blue book on the head and neck region. And in fact, there's also a dedicated issue on the soft tissue and bone tumor. And its latest edition is actually issued last year, so very updated. It's the 5th edition. So we can understand that the refinement of classification is definitely perceived as an improvement. It's both pathological diagnosis and also therapeutic options. And in this issue, what is so special about, of course, as the cover implies, so it includes, it's an integration of clinical, morphological, immunohistochemistry, and molecular genetics. And second of all, it's also in the editing and also the consensus meeting, there's also involvement of clinicians. So it adds to the relevance to the clinical management. So how is this updated soft tissue and bone tumor is about, and what's the special features? There's actually certain things that we can observe in these updated issues, and actually not only in this issue, but in general, pathological diagnosis and also classification. So first of all, we can imagine the molecular pathology will become more and more important as a diagnostic role. So while we do now relies on these tools actually quite frequently. Say, for example, there's a certain genetics abnormalities that are linked with specific histological subtypes. Say, in a well-differentiated adipose tumor or liposarcoma and even osteosarcoma. We can see from time to time MDM2 and CDK4 gene amplification, which we can detect as in this case, as in this example. So the green signal is actually the cluster amplification of the MDM2 in the case of liposarcoma. And also, say, for example, synovial sarcoma is also not uncommon in the head neck region, and we have all these gene rearrangement and so also related FISH, the SS18 break apart FISH test for the detection. So this is definitely has already been incorporated in the daily practice already. And also, well, not only the FISH, but also some PCR-based, and you can see that this is from the special issues about the fibroblastic. So we can see more and more of these molecular alterations are detected and associated with in the pre-existing histological entities. From nodular fasciitis is assumed to be a more reactive and reactive type of soft tissue, and to the fibrosarcoma. We have all these tools for the detection and molecular diagnosis in this soft tissue and bone tumor. And not only limited to the pre-existing, but we now also, in this latest WHO classification, we have these emerging entities. So say this is the few example that you can see that is actually the entities is named according to the gene rearrangement, say the NTRK rearranged spindle cell neoplasm or CIC. And these are the few pictures that are representing the, say, the NTRK B core and also CIC. And well, I think you have to agree with me that it actually looks pretty similar histologically. So it's actually a really challenge to, well, as a histopathology, I have to admit that it's from time to time it's challenging. So it's really important to observe these new entities and also to use the appropriate investigation for the detection. So these are the new entities, although they are not at all, well, for these few entities, for example, they are not at all specific to the head and neck region, but still they can be detected or observed. There's a case reported in the head and neck region. So will you expect to see from time to time, you'll see more of these emerging entities. So life seem it seems promising. So we have more molecular markers and even new entities that defined by rearrangement. But does it simplify the issues? No, I would say. So of course, emergence of entities like these NTRK rearranged spindle cell neoplasm definitely generate debates regarding the principle behind the definition of tumor entities. It's actually not something new. It happens in the neuropathologies already. And of course, it will lead to certain skepticism about the usefulness of histology or histopathology. But I think we're yet still, well, far away from that day, because I think that there are several reasons. So first of all, say, for example, these NTRK rearranged spindle cell neoplasm, histologically, it can shows a two morphological spectrum, one low grade and one high grade, and still that's still defining the clinical behavior of the spindle cell neoplasm besides the NTR that is susceptible to the NTRK inhibitor. And second of all, well, it's actually a very interesting name because you can see that excluding infantile fibrosarcoma. Infantile fibrosarcoma is also another spindle cell neoplasm harboring NTRK fusion that, but why it's become separated? Because it shows definite clear features, highly specific epidemiological, clinical, and pathological characteristics that separate it from the NTRK rearranged spindle cell tumor. So that means that, well, although we have some very promising gene rearrangement detected in certain neoplasms, so there's still a long way that how that can be incorporated into and how it affects the or how it affects or even, well, maybe replace the histopathology. I think we're still far away from this day. So, and of course, well, you may say that, well, it's a word from histopathology, so why trust you? So let's look at a challenging case. I love this case a lot because it's teach me a lot of things. So it's a 56-year-old lady presented with nasal obstruction with a very expansive tumor in the left maxilla, and the initial biopsy is a fibrosis lesion. All the molecular markers say MDM2, what I've mentioned about the osteosarcoma, MDM2, CDK4. We even wrote synovial sarcoma, and also the GNAS is for fibrous dysplasia. All are negative. So it's expansive, it looks aggressive, but still it's not entirely very destructive. So we're facing with a dilemma, whether it's an ossified fibroma, entirely benign entities, or osteosarcoma. So, well, in some areas it looks expansive, but these are not yet a definite invasion, because the bone itself has a lot of fenestration. So that means that ossified fibroma can still expand through their spaces. So we have sampled a lot in a lot of area, but still we are still facing with a tumor like this, expansive tumor like this. And how about the high power magnification? So say, for example, this is the this area is actually the ossified fibroma, and this side is actually the our case. So you can see that ossified fibroma can still exhibit certain atypia, and and also sometimes there may be some even little mitosis. But on the other hand, we can see that this tumor looks actually the same. So high power even not really helpful. So it's finally, we need to resort to like almost close to 50 blocks to find one focus that is convincing, which actually genuinely destruct the cortical border. So it's the only area that is convincing to be, so that we can call it, we can comfortably call it osteosarcoma. So I think it illustrates the point that, so although we have a lot of tools nowadays, I think still a lot of time the classification is still relies on the, there's still a role for the histopathologies and also the histological assessment. So I think it's all the time clinical and histological and also molecular combination. So, well, of course, even though without that area, the history will tell us, because very soon the patient has a recurrence, so it's osteosarcoma and has passed away. So lastly, just a few, well, it would be a shame not to mention about some selected soft tissue bone tumors specific to the head and neck region. I may say that well, as mentioned, they are always rare, but I think it would be helpful to talk about a few of these examples to have an idea about this selected head and neck soft tissue tumor. So first of all, is a entities called biphenotypic sinonasal sarcoma. So as the name implies, what's biphasic? Because it's comprising of both spindle cell and also a benign epithelial proliferation. So it's actually the spindle cell that is neoplastic, the spindle cell component. So, but it's associated with certain benign epithelial proliferation. So that makes the name biphenotypic sinonasal sarcoma. Definitely a rare tumor, but it's associated with a specific gene fusion, PAX3, and it's a low-grade tumor. It's a local recurrence is observed, but no distant metastasis are reported so far. And another one is also in the sinonasal region. It's called sinonasal glumangioperocytoma, or the more familiar name will be hemangioperocytoma. It's actually an indolent tumor, a lot of time indolent tumor with excellent survival, specific nuclear expression of a beta-catenin due to this CTNNB1 mutation. So that's helpful for our diagnosis with these beta-catenin immunohistochemistry. But there's definitely cases with more aggressive behavior, still dictated by certain histological parameters. And more importantly is the differential diagnosis, because it shows overlapping features with solitary fibrous tumor, synovial sarcoma, and MPNST. So I think it's more important to observe the list of differential diagnosis to understand that there's a certain soft tissue tumor that can happen in this specific sinonasal region. And very lastly, of course, we need to mention about some bone tumor, which is chondralsarcoma. In fact, chondralsarcoma is the second most common bone sarcoma after osteosarcoma. and quite a proportion of them arising in head and neck region. So, so this is just to show you the spectrum of the chondrosarcoma. Well, a lot of time it's still more histological diagnosis by sampling assessment. Certain mutations can be associated, but again, it can be this IDH1 and 2 mutation can be found even in benign cartilage tumor. So that means that they're not exactly specific for the chondrosarcoma, but just helpful as a differential diagnosis to differentiate between chondrosarcoma and osteosarcoma. So lastly, so these are the message that I hope to convey in this presentation, and look forward to the questions and comments later on. Thank you very much.